Hi, my name is Alison and today I'm presenting on shoulder dislocation. We'll cover the anatomy of the shoulder, then we'll talk about the etiology of shoulder dislocation, the clinical presentation, we'll talk about investigations, and finally the management. So to begin, the anatomy. So the shoulder is a highly mobile joint. It is known as the glenohumeral joint because of the humerus which articulates with the glenoid. It has a large range of motion, and because of this is inherently unstable because of the large surface area of the humerus articulating with such a small surface area of the glenoid. As a result of this, it's actually the most common joint dislocated in the body. So it has to be stabilized by many different things, otherwise it'll always be popping out. So we call these static and dynamic restraints. So the static restraints are ones that don't move. So these include the glenoid labrum, this part here, the glenohumeral ligaments, the glenoid itself and the humeral head itself, so the bones, and the joint capsule. The dynamic restraints are ones that can move with the joint, so these include the rotator cuff, the long head of biceps, and latissimus dorsi. So now onto the etiology. So the most common type of dislocation in the shoulder is an anterior dislocation, or anterior inferior is it technically, and this accounts for 95% of shoulder dislocations. And their picture on the right shows this. So the head of the humerus coming forward and down a little bit. Other types of dislocations include posterior and inferior dislocations, but these together only account for 5%. So an anterior dislocation occurs usually because of a force applied to an extended, abducted, and externally rotated humerus, or less commonly, a blow to the posterior humerus or a full-on outstretched hand. A posterior dislocation, which is quite uncommon, can be caused by seizures or electrocution, but can also occur through trauma, such as a direct blow to the anterior shoulder or force through a flexed arm. Now onto the clinical features. So dislocations, when they present, patient will have a painful shoulder, they will have acutely reduced mobility and a feeling of instability within the shoulder. Patients will often be reluctant to move the affected limb and can be seen cradling their arm with their other arm. So on examination, there's often asymmetry of the shoulders when you're comparing sides. There's loss of the regular shoulder contour, and there's an anterior bulge. Because it's usually an anterior dislocation, you often see the humeral head causing this bulge. And it's always important to assess the neurovascular status of the arm, because in some cases the axillary and suprascapular nerves can be impinged, and this can cause compromise. So here's a picture of a typical dislocated anterior dislocation of the shoulder. So you can see the prominent humeral head, the loss of the regular shoulder contour, and how he's holding his arm. He's reluctant to move it. He's supporting it with his other hand. So when we're diagnosing a shoulder dislocation, we're talking about in the history, like what kind of injury did they have? Did they fall in the outstretched hand? Were they surfing? Was it high force? Was it in a car accident? Are they experiencing pain? What's their age is really important, as it's more common in the younger age to have the anterior dislocation. And their hand dominance is important as well. So we're going to examine them, and it's a clinical diagnosis. So remembering that previous picture, that's the typical clinical picture you're going to see, and you're going to do a few tests to see if their shoulder is dislocated. So there's the apprehension test, which is this picture on the right. So you apply posterior pressure to the aspect of the humerus, and the patient experiences apprehension. There's the relocation test. So that's when you apply pressure on the anterior surface and that relieves the fear of the apprehension. And then the surprise test. So then when you release this pressure, the fear comes back. So if those 3 tests are positive, there's shoulder dislocation. Now, just a bit on associated injuries. There's a multitude of associated injuries with shoulder dislocation because there are so many ligaments and bony structures involved. Many things can happen. 2 of the main ones are Bankart and Hill-Sachs. So a Bankart lesion is when the labrum of the glenoid is disrupted, and sometimes also a bony fragment can be avulsed. So the arrow there is pointing to a avulsed bony fragment, and this occurs in 5% of shoulder dislocations. Hill-Sachs lesion is when there is a chondral impaction injury to the humeral head as it has contacted the glenoid rim. So the arrows are pointing to the injury there, and this is present in 80 to 100% of traumatic dislocations and 25% of subluxations. Some of the other injuries I've written here on the side, so you can get fractures of the greater or lesser tuberosity, you can get a humeral avulsion of the glenohumeral ligament or a Hagel, a glenoid labral articular defect or a GLAD, rotator cuff tear, axillary nerve damage, and an anterior labral periosteal sleeve avulsion. But there are also many others. I didn't include them all. Now we're going to talk about investigations. So we get a trauma shoulder series of x-rays. So that's at least 2, an AP and a Y, and also you can have axial views. So the AP view is shown over here. And you can usually spot anterior dislocations on the AP view as the humeral head is clearly not in the glenoid fossa. This is the light bulb sign in these x-rays here, and that suggests posterior dislocation. So the light bulb is that you can see the whole of the humeral head looking like a light bulb. And yeah, the Y view is also very helpful if it's not clear whether it's an anterior or posterior dislocation. If you suspect other injuries such as those ones I mentioned before that involve soft tissue, labrum, rotator cuff, things like that, an MRI is also useful as it can look at those soft tissue components more easy. Finally, the management. So, of course, we're always going to check, do a trauma assessment, that A, B, C, D, E, ensure they are resuscitated and stabilized. Everything else comes before this. Make sure they have adequate analgesia. If they're completely stable and they're on their road to recovery, we can then look at the shoulder. So more commonly, we do non-operative. So this is a closed reduction. There's many techniques. I'll go into them on the next slide, but just to mention a few: scapular manipulation, external rotation, and simple traction, counter traction. Always assess the neurovascular status pre and post reduction, as you want to check that no nerves were impinged during the reduction. And if the closed reduction doesn't work, manipulation under anesthesia or open reduction may be used. After the shoulder is reduced, it's always important to keep it immobilized for maybe a week or a few weeks, depending on what the doctor's advice is and what your type of injury is, and ensure physiotherapy. So that helps restore the range of movement and function and strengthen the rotator cuff. So our indications for non-operative approach are inferior dislocations, most anterior dislocations, and uncomplicated posterior dislocations. And also in the cases with no major arterial injury, no associated injury, such as those Bankarts, Hill-Sachs, those ones we talked about, and no fractures, because they'll need to be managed differently. So successful reduction is heralded by the clunk of the humeral head as it relocates and the return of the normal contour of the shoulder. Here's a few of the techniques used. So this one's scapular manipulation, where the physician places his hands on the back and pushes the scapula, and that relocates the shoulder. This is external rotation, so the patient's supine, their arm is adducted and the elbow is flexed, and then external rotation is applied, and that should reduce the shoulder. Here's the Milch technique and the Simpson maneuver, where the patient is prone and you have a weight suspended from the wrist, and this takes 20 minutes and the shoulder will gradually be reduced. Now there's also operative management. So of course we're going to do orthopedic referral. It can be open or arthroscopic depending on the type of injury, and the type of surgery is greatly dependent on the type of injuries. There's so many injuries associated with it. There's not just one operation that covers them all. So the indications for this, you haven't been able to do it at a closed reduction. There's displaced fractures, there's Bankart lesions, or there's a person who's dislocated their shoulder so many times, something operative needs to be done. And I'm just putting an example of surgeries over here. So arthroscopy at the top or an open surgery down here. So that concludes my presentation, and here's some of the websites that I gathered my information from.